The first domain is clinical translatability of results to human disease or condition, otherwise known as construct validity. What's the purpose of this domain? It's to assess whether statistically positive results in the reports of the preclinical animal research studies could result in clinical benefit. This evaluation focuses on both primary outcomes and secondary outcomes, or the main findings if the reports do not explicitly declare primary and secondary outcomes. Before we go to the signaling questions, you need to understand what we mean by model in this particular uh, context. In this context, model refers to the animal model used as substitute for human disease. For example, a mouse model of multiple myeloma. It also covers induction methods in animals in a non-diseased state that progress to a diseased state. Example, a rat model of behavioral alterations induced by forced swim test to mimic depression. It also includes animals which have been exposed to a treatment even if they did not have any induced human disease. For example, a rabbit model of liver resection, a canine model of kidney transplantation. The first signaling question is, did the authors use a model that adequately represents the human disease? Studies have shown that animal researchers frequently use disease models that do not adequately represent or relate to the human disease. The specific characteristics to consider include species, strain used, age, immune competence, and genetic composition as relevant to the particular disease being investigated. Other considerations include different methods of disease induction in the same or different species. How will you classify this signaling question? Classify this as yes or probably yes if the researchers reporting the study, we are going to call them study authors from now on. So if the study authors described information on the characteristics, different methods of disease induction, that's if appropriate, if they used more than one method of disease induction, and biological plausibility and provided evidence for the choice of animal model. Classify this as no information if any of the above information is missing. Classify this as no or probably no if the authors used a model that lacks biological plausibility. For example, it lacks the biological process that the disease affects. So the animal actually lacks the biological process that the disease affects, or has different immunocompetency compared to humans. The second signaling question is, did the authors identify and characterize the model? After choosing the appropriate model based on what the disease warrants, for example, species, sex, genetic composition, and age, have the authors performed studies to characterize the model? What do we mean by this? This is actually best explained with some examples. The first example is when the study authors were looking at a sepsis model. Sepsis is often induced through cecal ligation and puncture in the animal model. However, the effects of this procedure can produce variable sepsis severity. Another example is genes that induce disease may not be inherited reliably. So the resulting disease manifestation could be variable, and the interventions may appear to be less effective or more effective than they actually are because the disease was not inherited. Study authors wanted to use a knockout model to understand the mechanism of how an intervention works based on the assumption that the only difference between the knockout mice and the non knockout mice was the knockout gene. In this example, the fundamental difference, according to the study authors, is the knockout gene. So, any difference between the knockout mice and non-knockout mice is essentially the gene. That's the presumption. However, the animals used may still contain the gene that was intended to be removed, so the gene was not knocked out, or the animals may have other genes introduced during the process of creating the knockout mice. This means that any difference between the knockout mice and the non-knockout mice may be due to the introduced gene rather than the knockout gene. So, classify this as yes or probably yes if the researchers performed studies to characterize the model. For example, the animal has sepsis in a model of cecal ligation and puncture, so they confirm sepsis, or that the disease is present in the animal. For example, in genetic inheritance studies, you confirm that the disease is present in the animal, or the gene has been inherited reliably in the animal. Classify this as no information if it was not clear whether the researchers performed any studies to characterize the model. Classify this as probably no or no if the researchers clearly reported that they did not perform any studies to characterize the model. Before we go to the next signaling question 3, you need to understand what a therapeutic window means. The intervention may be effective only at a certain point in the disease. This is called the therapeutic window. Now, in humans, it may not be possible to recognize and initiate treatment during the therapeutic window because of the delays in appearance of symptoms and diagnosis. Therefore, there is no rationale in performing preclinical studies in which the intervention cannot be initiated during the likely therapeutic window in humans. Okay, the third signaling question is where the method and timing of the intervention in the specific model relevant to humans. Now, this can be split into two categories, the intervention, and the explanation is slightly different for pharmacological or biological interventions compared to non-pharmacological interventions. For pharmacological or biological interventions, there may be a therapeutic dose and route which is likely to be safe and effective in humans. But some researchers may use doses in animals at levels that would be toxic when extrapolated to humans, and therefore unlikely to be used and not relevant to humans. It is preferable to use the same route of administration for animal studies as planned in humans, since different routes may lead to different metabolic fate and toxicity of the drug. For non-pharmacological interventions, the feasibility of the method of administration in humans should be considered. For both pharmacological and non-pharmacological interventions, you have to consider whether the intervention was initiated prior to induction of disease in animal models, which may not reflect the actual use of the drug in human clinical situation, or outside the likely therapeutic window in humans. Some examples for this are given. So the treatment may be usually administered intravenously in humans, but is administered intraperitoneally in mice. This can have different ways that the drug is processed and can have implications in the effectiveness and safety. The second example is ablation. Ablation can be achieved by irreversible electroporation, IRE, which involves passing high voltage electricity. But let's say you want to consider irreversible electroporation in brains. But this can be done only after human studies confirm that there are no residual effects of high voltage electricity in the surrounding tissue, not requiring ablation. Until then, testing of irreversible electroporation in animal models of brain tumors is unlikely to progress to human trials and will not be relevant to humans, regardless of how effective it may be. Here, it's simply not possible in humans until further studies in humans in other areas confirm that what are the residual effects of high voltage electricity on the surrounding tissue. Another example is the treatment may be initiated prior to induction of disease in animal models, which actually does not reflect the actual use of the drug in human clinical situation. You don't give the drug to the humans before the disease starts, unless of course it's a prophylactic study. Here we are talking about therapeutic studies, or it is outside the likely therapeutic window in humans because the symptoms have not yet appeared. Okay, how are you going to classify this question? Classify this as yes or probably yes if the dose was relevant in humans and the timing and route of administration in the animal model for pharmacological or biological interventions, or the method for non-pharmacological interventions was similar to that in humans. Classify this as no information if the authors did not provide a rationale for choosing the dose, timing, or route or method of administration. Classify this as no or probably no if the authors mention the dose, timing, and route or method relevant to humans but used a different dose, timing, or route or method. So they say this is how it's done in humans, but we are going to do it in the wrong way anyway. Okay, now we come to the signaling question 4. But before we go to the signaling question 4, you need to learn a little bit of background about what surrogate outcomes are and what are the implications of using surrogate outcomes. A surrogate outcome is an outcome that is used as a substitute for another more direct outcome along the disease pathway. There are some situations when a surrogate outcome is likely to be valid. The situation is the surrogate outcome is the only pathway that the disease can cause the clinical outcome. Therefore, the intervention should act in this pathway, and it actually causes a change in surrogate outcome, which leads to a change in the clinical outcome. We are now talking about the ideal scenario when the surrogate outcome is likely to be valid. But what happens in reality? What are the problems with surrogate outcomes? There are other pathways which are not affected by the intervention through which the disease can cause the clinical outcome. That means the validity of the surrogate outcome will be decreased. So, if the intervention affects the clinical outcome, so here let's talk about the first situation. The intervention affects the pathway between the disease and surrogate outcome, but actually there are alternate pathways by which the disease affects the clinical outcome. So even if there is a change in surrogate outcome, that doesn't translate to an equivalent change in clinical outcome because the disease affects the clinical outcome in alternate pathways. The second situation is where the intervention affects the clinical outcome through pathways unrelated to the surrogate outcome, which means that it may result in some change in surrogate outcome but it might affect the clinical outcome directly. So change in surrogate outcome does not necessarily relate to a change in clinical outcome because it has affected the clinical outcome in an alternate pathway. Some problems related to surrogate outcomes that have been observed in clinical studies. Um, there are several examples of improvement of surrogate outcomes but worsening of clinical outcomes. First example is ventricular ectopic beats. Ventricular ectopic beats are essentially additional beats that originate from the ventricle of the heart. And these are associated with adverse prognosis in patients with heart attack. Class 1 antiarrhythmic agents effectively suppress the ventricular arrhythmias. They suppress the ventricular ectopic beats in animals and in humans, but increased human mortality when evaluated in randomized controlled trials. So, here, just one step back, ventricular ectopic beats, if they are present, they have a bad prognosis for patients with heart attack. So the theory is that if you suppress these ventricular ectopic beats, then it should improve the outcomes in humans. So class 1 antiarrhythmic agents, they effectively suppress the ventricular ectopic beats, but actually cause more mortality in humans. It resulted in tens of thousands of deaths in people with non-lethal arrhythmias because of the reliance on the surrogate outcomes. Another example is people with heart failure. In people with heart failure, angiotensin converting enzyme inhibitors, or shortly called ACE inhibitors, improved exercise capacity and decreased mortality as demonstrated by randomized controlled trial. But other classes of drugs, such as milrinone and epoprostenol, caused increased cardiovascular mortality despite improving the exercise tolerance. So if you are only using exercise capacity or exercise tolerance as a surrogate outcome, because ACE inhibitors actually improved exercise capacity and decreased mortality, that's the basis why you are using that as a surrogate outcome. But if you use that in another class of drug, then it actually increased cardiovascular mortality. Another example is diabetes. In diabetes, glycosylated hemoglobin, or HbA1c, is used as a surrogate marker for clinical outcomes. It is generally considered as glycemic control levels of HbA1c. However, some oral hypoglycemic drugs that reduce HbA1c increase the risk of cardiovascular events. That is despite having a reduction in HbA1c that indicates glycemic control. Some more examples. In cancer, only 15% of the 36 cancer drugs approved by the US FDA by what is called an accelerated pathway between 2008 and 2012, on the basis of reduction in tumor size or volume, progression-free survival, or disease-free survival. Now, these outcomes are generally considered as cancer control. So, reduction in tumor size or volume means the cancer shrinks. Progression-free survival means the cancer doesn't progress more. Disease-free survival means the cancer doesn't recur. So, based on these outcomes, 36 cancer drugs were approved by the US FDA by accelerated pathway based on surrogate outcomes between 2008 and 2012. But actually only one, or 15%, not one, I think that will equate to about 3%, sorry, 3 drugs. Only 15% of the 36 cancer drugs actually improved overall survival. In 18 or 50% of the cancer drugs, it was clearly demonstrated that there was no improvement in overall survival with uncertainty remaining in the remaining 35% of the drugs. Okay, so in 15% of the drugs, I think that would equate to 6 rather than 5 or 6 drugs, not 3 as I mentioned before. So about 5 or 6 drugs resulted in improved overall survival. In 18 drugs, which is 50% of the drugs, it was clearly demonstrated that there was no improvement in overall survival. In the remaining drugs, there was uncertainty as to whether there was improvement in survival or not. Now, these researchers took only the 18 drugs where it was clear that the drug did not cause any improvement in overall survival. And they measured, okay, maybe they did not change the overall survival. Could it have affected the health-related quality of life? The health-related quality of life information was found only for 7 of the 18 drugs. Of this, only 1 of the drugs improved health-related quality of life. 2 drugs worsened the health-related quality of life, and there was no difference in the health related quality of life or inconsistent results about the health related quality of life for the remaining drugs. Now, some examples of clinical and surrogate outcomes. Broadly, any lab based or radiology based outcomes or surrogate outcomes. Example, liver function tests, bone mineral density. Some examples of clinical outcomes are death, stroke, limb paralysis. Okay, now we come to signaling question 1.4. Having understood what a surrogate outcome means, what the pitfalls of the surrogate outcomes are. The signaling question 4 is if the study used a surrogate outcome, so that means it's only applicable when a surrogate outcome is used. Was there a clear and reproducible relationship between an intervention effect on the surrogate outcome and that on the clinical outcome? And the surrogate outcome could have been measured at the time chosen in the preclinical research. So it has to be the surrogate outcome which is measured at the time chosen in the preclinical research. And is there a relationship between the intervention effect on the surrogate outcome and that on the clinical outcome? This question is applicable only if a surrogate outcome was used as the outcome based on which the conclusions are based. It's usually the primary outcome based on which the conclusions are made. So this question is applicable only if a surrogate outcome was used as the outcome, as the primary outcome or the main outcome. Some examples: preclinical animal research studies may use gene or protein levels to determine whether an intervention is effective. Now, if the gene or protein lies in the only pathway between the disease and the animal equivalent of the clinical outcome, a change in expression level or activity of the gene or protein is likely to result in an equivalent change in the animal equivalent of the clinical outcome. Okay, that's a little handful. Let us simplify this even further. Is apoptosis at 24 hours? That is the surrogate outcome here. So you're looking at apoptosis. That's the drug effect, apoptosis. If is apoptosis at 24 years in the animal model correlated with improved survival in animals? Or it could correlate with improved survival in humans too. That is not the problem. It should be correlated with some form of what we consider as a clinical outcome or a clinical animal equivalent for the clinical outcome. Another example of this signaling question simplified to the context of research can be: are aberrant crypt foci, which is the surrogate outcome, in animal models correlated to colon cancer in these models? Okay, so an intervention is aimed at changing the number of aberrant crypt foci, but the question then is, okay, is aberrant crypt foci in animal models correlated to colon cancer in these models? How will you classify this question? Classify this as not applicable if a surrogate outcome was not used, i.e. the outcomes were animal equivalent for clinical outcomes such as death or limb paralysis. Classify this as yes or probably yes if the authors used a surrogate outcome and the relationship between the surrogate outcome and clinical outcome or its animal equivalent was high as shown in multiple studies. So it's just not enough if it is shown in a single study. It has to be shown in multiple studies that there is a relationship between the surrogate outcome and the clinical outcome or its animal equivalent. Classify this as no information if the authors used a surrogate outcome but did not provide a rationale for choosing the surrogate outcome. They simply used an outcome, let's say liver function test or bone mineral density, but they did not provide you the relationship between bone mineral density and fractures. They did not provide the relationship between aberrant crypt foci and colon cancers. Classify this as no or probably no if the authors reported that the relationship between the surrogate outcome and the clinical outcome or its animal equivalent was low or was inconsistent in different studies. The next signaling question also relates to the surrogate outcome. So signaling question 1.5 is, if the study used a surrogate outcome, did previous experimental studies consistently demonstrate that a change in surrogate outcomes by a treatment led to a comparable change in clinical outcomes? So, how is it different from the previous signaling question? Of course, this signaling question is also applicable only if a surrogate outcome was used as the main outcome. A simple association between a surrogate outcome and clinical outcome is not sufficient. There, it was only in the previous signaling question, we were only interested in a relationship. Here, we want to know whether a change in the surrogate outcome by the treatment results in a comparable change in the clinical outcome or its animal equivalent for it to be valid. Okay. This change has to be consistent. That is, most studies showing that a treatment results in a comparable improvement in clinical outcome or its animal equivalent. For example, in the previous signaling question, you are simply happy if bone mineral density was shown to be associated or shown to have some relationship with fractures. For this signaling question, you need to show that a particular intervention, for example here sodium fluoride, if it increases bone mineral density, it also results in decreased in fractures. But in reality, what happened was sodium fluoride caused more fractures despite increasing bone mineral density, even though there was an inverse relationship between bone mineral density and fractures. Even though that relationship existed, simply increasing bone mineral density using a drug actually resulted in more fractures, not less fractures. Okay, to summarize, the difference between this signaling question and the previous signaling question, that's 1.4, is that the previous question just evaluated the association or the relationship between the surrogate outcome and clinical outcome, whereas this signaling question assesses whether there is a corresponding change in the clinical outcome if there was a change in the surrogate outcome. And that's why I have underlined change here. Now, how will you classify this? Classify this as not applicable if a surrogate outcome was not used. For example, the outcomes were clinical outcomes such as death or limb paralysis. Classify this as yes or probably yes if a change in surrogate outcome by a treatment resulted in comparable change in the clinical outcome or its animal equivalent, and this was demonstrated consistently in multiple randomized controlled trials or at least in multiple centers. Classify this as no information if the author used a surrogate outcome but did not provide a rationale for choosing the surrogate outcome. Classify this as no or probably no if the authors reported that a change in the surrogate outcome by a treatment did not result in a comparable change in the clinical outcome, or that the relation between the change in surrogate outcome and clinical outcome was inconsistent in different studies. So either condition. One is, in a single study, you show that a change in the surrogate outcome does not result in a comparable change in the clinical outcome. Or we might also classify this as no or probably no if different studies are showing inconsistent results. Signaling question 1.6 and the last question in this domain. Did a systematic review with or without meta-analysis demonstrate that the effect of an intervention or a similar intervention in animal model was similar to that in humans? Okay, let's find out what we mean here. Now, we want to know whether a systematic review, and that may or may not include meta-analysis, that should demonstrate that the effect of an intervention or the intervention, a similar intervention in animal model, that's okay, was similar to that in humans. So the effect of an intervention on animals in an animal model should be similar to that in humans for this for that to be clinical translatability. Okay, so the best way to find consistent evidence to support or refute the validity of surrogate outcomes and the comparability of the animal equivalent of clinical outcomes to that in humans is by systematic reviews. So, is limb paralysis in animals equivalent to limb paralysis in humans? These are clinical outcomes, but even here, is this equivalent? Is this the animal equivalent for clinical outcome, for a for an outcome in human? Now, failure to conduct a systematic review of preclinical studies prior to the start of the clinical research and presenting selective results to grant funders or patients is scientifically questionable, likely to be unethical, and can lead to delays in finding suitable treatments for diseases by investing resources in treatments that could have been predicted to fail based on the systematic reviews. So if you don't conduct systematic reviews on preclinical studies before you start a clinical research, I mean, the best case scenario is that this it's of questionable scientific value, but actually it is likely to be unethical, and it can lead to delays in finding suitable treatments for diseases by investing resources in treatments that could have already been predicted to fail based on these systematic reviews. So, for example, if an intervention improves recovery from stroke, which is the animal equivalent of a clinical outcome in a mouse model of stroke, does it also improve recovery from stroke in humans? If so, other interventions can be tested in this model. Okay, so that is the bottom line. You have to do a systematic review before you start a clinical study. Not just a systematic review of clinical studies, you should also do a systematic review of preclinical studies if you are thinking about first in human studies. Okay, how will you classify this signaling question? Classify this question as yes or probably yes if the study authors provide evidence from systematic reviews of preclinical animal research studies and clinical studies that the intervention or similar intervention showed treatment effects that were similar in preclinical research studies and clinical studies. Again, we go back to the previous example. An improvement of stroke in animal models resulted in an improvement of stroke in humans. Classify this as no information if the study authors do not mention any systematic reviews related to the topic. Classify this question as no or probably no if the study authors provide evidence that the intervention or a similar intervention showed that the treatment effects were different in preclinical research studies and clinical studies. Okay, note to the assessor is not expected to search for the systematic review. The study authors need to provide evidence from systematic reviews.